Hi there. Good morning to everybody. This is a bit of a interesting circumstance for our profession right now with the quarantines and the limited treatment that we're down to. So I thought we'd just do a webinar here on precision guided implant placement. This will be about 45 minutes long, and after that we'll have some questions and a short quiz at the very end there. So a little bit about myself. I'm practicing in Burnaby, British Columbia, and I've been practicing for about 12 years. And over those 12 years, I went from basically doing the basic drill and fill dentistry to starting to kind of get an interest in implantology, taken some courses here in GBR, PRF, full mouth rehab, sinus grafting, and really enjoying my practice now. I never thought I would be doing any of these things. Like I said, I'm a general practitioner, but through some of these mentors I've come across through the years, I've really been able to kind of expand my practice into this realm. So done about over 1,000 CE credits over the years, and I've done about 2,000 implants or so over the years. So a lot of what I'll be talking about today is going to tie into this quote from Sun Tzu, who was a famous Chinese military strategist from the 5th century BC. He says that a victorious warrior wins the battle first and then goes to war, while a defeated warrior goes to war first and then seeks to win. I think there's a key difference here in the mentality of a winner. The mentality of a winner is that you're always prepared for the battle before you go to war. And if you're prepared and you can see the path to victory, you can visualize it, you'll often get there. If you try to, go into the situation unprepared and hope that you get a great outcome, oftentimes you can get unintentional outcomes that way. So in my mind, guided surgery, digitally guided surgery, that is all about being extremely prepared going into treatment. Now, how that quote relates to implantology, I hope to kind of share that with you throughout this lecture. So we'll start a little bit with a review of the program today. So we'll start with the Hyosin One Guide System overview. It'll be a brief overview of the kit and the guide itself. And then I think I want to get into some cases. I feel you learn a lot by looking at actual clinical cases, that the types of cases that many of us do see in our chairs from time to time, and see how the guide can help us with those types of cases and overcome some of those challenges. So I'll start with a simple posterior case. And in that case, I'm hoping to showcase the One Guide System workflow step by step. Then we'll get into some immediate placement applications. I'll show you some cases where we were able to use the One Guide system to do immediate implant placement. And then we'll get into guided bone regeneration with concurrent fixture placement. So more of a challenging type of a situation, but this will illustrate the power of the guide. And I'll summarize at the end with some of the benefits of using a digitally guided workflow. So let's start with the guide itself. Now, the guide itself usually looks something like this, what you're seeing on the screen there. And the guide is 3D printed and usually has like access holes through which we place the implants. Now, the first thing usually you see with a guided system is the kit itself. And now, I don't know if you're anything like me, but whenever I see a new implant kit, I always get overwhelmed. Just so many drills, so many things going on. You know what? I'm very comfortable with the way I'm doing it right now. I don't want to change. So I want to kind of get into this kit and simplify it. This kit really can be broken down into two different types of systems. So there's one half of the kit that generally is used to place fixtures that are between 3.5 and 4.5 diameter. And then the other half of the kit is designed to place fixtures that are 5.0 diameter. And each type of fixture has corresponding drills, as you can see. Now, most of the drills here either go into one of these two types of systems, either the 5.0 or the 3.5 to 4.5. And which system they fall into tends to be dictated by the thickness of the sleeve. I don't know if you can see the cursor here. This is the drill sleeve. And here you can see it's measured at 5.7. Over here it's measured at 5.0. And they'll go into the corresponding guide sleeves here, 5.1 and 5.8. So that's what dictate what drills goes into what type of sleeve. So let's start with some of the more basic instrumentation here. Tissue punch. Nice thing about guided treatment is that a lot of times you can do flapless procedures, and from a patient perspective, this is a big selling point. Also, it's extremely minimally invasive. A lot of times patients will get treatment with a tissue punch and tell me that they didn't feel anything at all, that this was no different than getting a filling done. So the tissue punches that you can see are, let me back up here. So the tissue punches are highlighted here. The two on the left are designed to be used with the narrower sleeves, and the two on the right are designed to be used with the thicker sleeves. Now, how do you use a tissue punch? Pretty straightforward. You put the guide on, drill in with the tissue punch. It'll make a circumferential cut, and then you can usually peel off the little fragment of tissue there. Oftentimes, there's a slope to the ridge. So what I do is I'll go in with the guide first, make my little outline, and then I take the guide off and I'll do a circumferential, kind of a rotating type of cut to get all the tissue off. And then I'll use like a periosteal elevator, a P24G or something, to just peel off that little circular flap of tissue. Usually the next step we go to is the initial drill, okay? Now this is the first drill we typically use in a guided system, and it acts like a pilot drill. Kind of makes the guide path. So as with the tissue punches, the initial drill has two different types of diameters. The two on the left you can see here are designed to be used with the narrower sleeve, and the one on the right is designed to be used with the thicker sleeve, okay? So initial drill goes in through the slot. The drill length is about 5.7 millimeters, so it's not really the length of your osteotomy, and it will make your initial hole. Now, sometimes people wonder, why do we need an initial drill? Why can't we just go to a guided drill right away? And that comes down to the fact that you want this whole procedure to be guided in terms of the trajectory of your drill should be dictated by the sleeve. So if you use a longer drill like the one on the right and you go right from the start, at the initial contact that drill makes with the flap, with the gum tissue or the bone, it's not guided. The sleeve has not engaged, the sleeve of the drill has not engaged the sleeve of the guide because it's long, right? So that's why the initial drill being shorter, it allows you to at least get the drill sleeve to engage with the guide sleeve so that it, as you go apically, your drill is guided in the right trajectory. Okay, so that's why the initial drill is always the first drill that you use. And now when you go to the subsequent drill, you can actually have the drill hit the bone and the sleeve at the same time and gets double fixated guidance there. We also have flattening drills, okay? One of each, again, for each type of hole. Okay, and that's if you have a sloped ridge, you can flatten the ridge before you go in with the guide drill, because sometimes if you do have quite a sloped ridge, your guide drill won't go all the way down to length. If it's not going all the way down to length, it means that the flattened surface of the drill sleeve, I should say, is getting caught up in the bone. It's not letting it go all the way. So you get rid of that little bit of bone with the flattening drill, and then the guide drill goes down all the way. Now we're kind of getting down to the meat of the kit here. These are all the actual drills we use to make the osteotomy. And really they're in lengths 6, 7, 8.5, 10, 11.5, and 15. And their diameters are 2.2. Here, that's usually your initial drill. And then these ones here are for the fixture 3.5, fixture 4.0, fixture 4.5. and similar sort of arrangement for the ones here on the right side, designed to be used for the 5.0 fixtures. Okay, so let's go back to this slide here, and I want to kind of show you a very important point here. Note that the drill sleeve here, for instance, for the wider sleeves is 5.7 millimeters, but the guide sleeve that'll be accepting the drill sleeve is 5.8 millimeters. Why is there a discrepancy there? Why can't they be exactly aligned? The truth of the matter is that if this was 5.7 millimeters, then as you drill down and you start to engage in bone and generate torque, there's a high chance of the drill actually getting stuck in the guide because of the frictional lock. This was something that was changed in the newer version of the one guide, and now we have a 5.8 hole here to allow for a little bit of give so your drill doesn't get stuck. Similarly, over here, you have a 5.0 millimeter width to the drill sleeve, but a 0.1 millimeter diameter discrepancy between the drill sleeve, the guide sleeve, and the drill sleeve here. Okay. So this slide again kind of underscores that point, why we have that 0.1 millimeter difference, and we'll be coming back to that because as we start getting into the fixture drivers, that give to bypass the drill getting stuck becomes more and more important, and it's kind of fundamental to the design of these drills and these sleeves. So this is kind of a close-up look at a typical one guide drill. You see that there's a stopper here. This stopper is what you drill down to. This makes sure that your apical coronal dimension of the osteotomy is fully controlled throughout the osteotomy. The black line here is the desired coronal position of the fixture. Now, this is something you'll digitally plan beforehand. And this position is built into the guide, this orange diagram here. So the guide will decide where that position ends up being. If you want that position lower, guess what? Your guide here is going to be sitting lower. If you want that position higher, your guide will be sitting higher. The drill is always standardized, but the guide is customized. And that's kind of the magic behind being able to use a standardized drill system to do these kind of surgeries. So the sleeve, as we talked about, is built into the drill, unlike other implant guided systems. And the standard distance between the stopper and where you want the coronal position of your fixture is always going to be 10.5 millimeters in all the drills in this system. Okay. So there are some other drills here that I haven't gone into, like the F4.5 cortical drill. Where you use that is if you're placing a 4.5 millimeter fixture in harder bone. And you find that you've kind of now drilled to the 4.5 drill here, regular drill, and your implant still kind of, when you go to put it in, it torques out halfway down the osteotomy. You know you need to widen it a little. So that's where you can go in with the F4.5 cortical drill, just to widen it and allow the implant to go into the osteotomy. Similarly, for the 5.0 fixture, if you're in very hard bone, then you can use the F5.5 drill similarly. So now, once the osteotomy is done, we're ready to place the implants in. And usually we'll use the no mount fixtures first. You can see there's two different types. For the narrow sleeves, we have a mini platform and a regular platform sleeve. And for the mount driver, I should say. And for the wider drill sleeves, we have the regular platform wide here. Okay, so let's look at that a little bit. Now, when the implant's going in, remember, we always tend to under-prep our osteotomies. And now when we're putting the implant in, there is going to be some torque that builds up as the implant goes in. So even with that 0.1 millimeter give between the sleeve of the drill and the guide, you are going to get a propensity for this to get stuck. So that's why they've made this actually 0.2 millimeters narrower. So you'll see the diameter here is 5.6 millimeters as opposed to the 5.7. And once we place the implant in with this no mount fixture driver, we want to then finish it off with the torque wrench, okay? So this allows us to really control the torque as it's going in. So this is where we usually switch over to the torque wrench, and we can use these no mount fixture drivers. And you'll notice that at this point, the torque tends to get even higher. So to compensate for that, this sleeve gets even narrower. It's now 5.4 millimeters in diameter and shorter. So previously the sleeves are 8.5 millimeters. Now we're at 5 millimeters. So this limits the contact area between this and the sleeve of the guide to minimize the chance of things getting stuck. Okay. So this was a very kind of fast crash course in the One Guide system here, because I'm more interested in showing you guys clinical applications of it. But just to kind of summarize how we would typically do an osteotomy. So say we were going to do a flapless approach and we were putting in a 4.0 fixture. First step, tissue punch. If need be, we can use a flattening drill. Now this isn't always necessary. Then we go in with our initial drill to create the pilot hole. So this is actually the first drill of the osteotomy. Now, if we're in soft bone, all we need to really go in is to the 3.5 millimeter drill down to length, and we're ready to place the implant. So 2 osteotomy drills and we're ready to place the implant. If it's more of a normal density to bone, we can go 1 drill higher to the 4.0. And if it's hard bone, then we can usually jump straight from the 3.5 drill to the 4.5 drill. So at most you're using 3 drills, and at the very least you can use 2. So it's pretty fast, and that's one of the things I loved about it. Now, we've gone over the kit very quickly. I'm going to briefly kind of go over the guide. Okay, so you'll see that the guide looks like this. This is kind of a virtual schematic of the guide. These holes here are where the osteotomies get conducted through. This little bar stabilizes cross-arch stabilization to prevent flexure of the guide as torque starts getting generated. Also, you'll see these little windows here. The windows are there to ensure that the guide is fully seated. The guide, you'll notice, is also made out of a transparent material, which allows us to visualize the full seating of the guide, which, as I'm sure I don't need to tell you, is extremely important in guided surgery. So how this differs from the older generation of guides is the sleeves are 3D printed into the guides as opposed to having metal sleeves bonded in, which does reduce a lot of the error factor. Anytime we're bonding in sleeves into a guide, there is a bit of error that can be introduced into the system. Also, this can vastly reduce the cost of generating the guide. So not having a sleeve there also makes it so that we can have less interdental distance and still be able to use a guided protocol. So currently with the One Guide system, we can do a fully guided surgery as long as we have less than 6 millimeters of interdental distance there. Now, the guide material itself is a polyjet monomer. It's actually Med 610. It's quite rigid, which is what you want in a guide. You definitely don't want flexibility in a guide because that can lead to you going off trajectory. And it's made by a company called Stratasys, which, interestingly enough, works with companies like Lockheed Martin and Mercedes in helping them find their 3D printing solutions. So I take comfort in the fact that we've got Fortune 500 companies working with Stratasys, and we're using their guide material. So there's other companies that use them: Airbus, Honda, Ford, Siemens, and Volvo. So it's a pretty reputable company, and it's a very, very good guide material. So that was your quick crash course in the One Guide system. Now, Hyoson and AIC do offer more courses, more detailed courses on the One Guide system. By no means am I expecting you to understand how to use the kit based on what I quickly went over there. But for those people that didn't have a background in it, I hope that it kind of helped. Now, this is the part that I'm kind of excited about showing, is let's work through a case together here and how we could use a guided protocol to make this a little more predictable for ourselves. So here we have a 2.6, it's a molar. upper left first molar, and we have the palatal root there. It was diagnosed with a vertical root fracture. You can see a lesion there on the root. Okay, so we decided to have this tooth extracted, and we did a socket preservation. Okay, so this was a double membrane technique socket preservation. You see nylon sutures there with a PTFE membrane, and there's a collagen cytoplast RTM membrane underneath that. I use 100% cancellous allograft for this case. Okay, so 4 weeks later, we removed the membrane. You can see a bit of a pseudomembrane there developing underneath it, bit of soft tissue closure, some unincorporated graft particles exfoliating there. We waited about 4 months, and at that point, we decided to go ahead with the guided implant treatment. So the records we obtained to get this going were some PVS impressions, or you could take digital impressions. What you're trying to do is you want to get your One Guide team the topography of the site. And then we took a CBCT scan. Okay. And then we send all that information virtually through LabStar. Okay, so in our office, we use analog impressions still. So we sent those via mail, but the CBCT was uploaded via LabStar. And this is something my assistants will do for me. I'm usually not involved in any of this. The entire records appointment they take care of while I tend to be doing other things. So it's nice that it's kind of out of my hair. Then the One Guide team will actually plan where the implants should go based on principles of implant placement. So then they'll generate a report for you. And usually the report will come to me in my inbox in an email, okay, like this. And I'll look through it. Now, One Guide team is actually pretty good at finding the ideal position for the implants. But sometimes I want to be more involved. So then we can usually set up a team viewer meeting where I tend to be more involved with it then, or if I'm not happy with the plan or the positioning of the implants, we can use a virtual web conferencing software to take care of that. And it usually takes me about 5 to 10 minutes to get that sorted out. So it's pretty quick and easy. So back to the report. So this is what it looks like. The doctor always has to digitally approve it. So in this case, we were planning an implant for tooth number 26. And you can see the bone had healed sufficiently for us to plan a 5 by 8.5 implant. We have to be mindful of the maxillary sinus there. So what I love about this is now this is true reverse treatment planning. What we see is where the tooth ought to be, and we want the implant to line up with that, okay? It has to be a certain amount of distance from the gum, usually about 3 to 4 millimeters to respect biological width. I want to see where the access hole will come out of so that I'm eliminating any sort of cantilevers. I want to see how the tooth will sit in occlusion so we're not in crossbite. And I want to check the mesiodistal position. Okay, so when I look at this report, I see that we have a little zone, a little green zone around the implant. This is the safety zone that the One Guide team works within. So usually the measurement here is 1.5 millimeters. So you want to be 1.5 millimeters away from the adjacent teeth roots. And you also want to be about 3 millimeters away from any sort of anatomical structure. As you can see here, we're very close to the maxillary sinus. So in this case, we were anticipating a slight sinus bump. But I'm happy with the mesiodistal position of this implant. Now we look at the buccal lingual position. Again, I want to see where the access hole lines up. And usually you want your access hole to line up with the central fossa, and that should line up with the buccal cusps of the opposing mandibular teeth. And you can see that's well in line. And now this is the apical coronal position. The yellow line here illustrates where the gum tissue is. And I want it to typically be about 3 millimeters to 4 millimeters below the gum to respect biological width. So in this case, we have that 3.01 millimeters that we're looking for and 1 millimeter subcrestal here. Okay. So I find this quite powerful to be able to plan the position in three-dimensional space before I've even touched the patient. It truly is simulated surgery. We also have a qualitative bone density analysis, and as expected, we're getting about D3, D4 bone here. Keep in mind that this is the posterior maxilla. It tends to have softer bone, and we grafted recently, about 4 months before the scan was taken here. So then this is what the stent will look like. I'm happy with it. I can see the windows there. I can see the crossbar here for cross-arch stabilization. And then we go ahead and proceed with the treatment. So I looked at this case and I said to myself, geez, I have a lot of keratinized tissue here. I don't think I need to flap. So we put the guide on, made sure that it was seated. And remember, the first step here is tissue punch. Now, I'm going to go through this kit one more time just to kind of review it. So if we're going to tissue punch and we're using a 5.0 by 8.5 implant here, this is the first tissue punch that I'm going to use here. So we go in, make that kind of cylindrical cut, and then I usually tease that off with a periosteal elevator. I like to keep that little bit in saline, in cold saline, just in case after my implant goes in, if I, for some reason, don't get adequate torque for me to feel comfortable placing a healing abutment, I can leave it with a cover screw, and I'll actually cover it with this little patch again, just to kind of help with the closure. Okay, so next step is the osteotomy. So this is a little osteotomy cheat sheet, and we want to see this scan again. Once again, what was our bone density? So remember, this is softer bone. So I'm probably going to want to use the soft bone protocol. So we're doing a 5.0 fixture. Soft bone protocol means I'll be using an initial drill, then typically a 3.5, and then my 4.5, and then I should be ready to place the implant. So initial drill, that's the one we chose. Okay, remember we're using a 5.0 fixture, so we want to go for the wider sleeves. Then we grab that drill, the 3.5 by 8.5, and then the 4.5 by 8.5 drill. And now we're ready for fixture placement. So those are the two fixture drivers we use. First, we use the no mount driver, and then we use the actual fixture driver. Okay, remember that the fixture driver is, the no mount driver is narrower as the implant's going in, and the fixture driver is narrower and shorter, so that we don't have the issue of the drill getting stuck. Okay, so this is what it looks like. So this is where I put the implant down to. So once the guide lines up with the top of this drill sleeve, I know I'm at the planned length. This right here means I'm at the apical coronal position that I treatment planned. Okay, these yellow bars here signify the hex positions, the internal hex position of the implant. So if you want to use, say, a stock abutment, or you want to place an immediate temporary, and it's a hexed type of temporary, then you're going to want to line this up with this little slot here so that you have correct orientation for your temporary. Okay. If, however, you're using a non-hexed temporary abutment, or you're not using a temporary abutment at all, and you're going to be using a custom abutment at the end of for the final, which I usually do, then it doesn't really matter if you line this up with that slot or not. Okay, it's just an interesting feature. So the implant went in. You can see we got pretty good torque there. There's the implant in place, and then we put the healing abutment on. Okay, so that's where we wanted it planned virtually. Okay, and that's where we got it planned. Okay, so right on the money. Usually something like this takes no more than 10 minutes to do. It's actually longer. It takes me longer to do a DO filling these days than one of these. Okay, so we're going to kind of move along. I wanted to show you some other applications of the guide here. So this is a case where we use the guide to do an immediate molar placement. Okay, we had a tooth 4-7. It had some periodontal bone loss and was starting to get loose, had unfavorable root anatomy. The patient decided to have it replaced. Okay, so this is the one guide report. I'm going to skip through some of the record steps. Just want to get down to the osteotomy on this one. So we use a 4.5 by 8.5 here. That's what we were planning. Okay. Now, This is more challenging than the case I just showed you. And the reason is we're now doing an osteotomy over an irregular topography. Look where the implant's planned. That's along a slope. Okay, doing an osteotomy along a slope, especially if it's a slope deep within a socket on the last molar, that is not an easy area to control trajectory on. Okay, and this is where I think the guide really helps us, because we can plan for the ideal implant position, but if our hand can't necessarily guide our osteotomy there, then we're not going to get our implant in that position. So if you can have a tool like a guide to help you get your implant in that position, then you can make your procedure just so much simpler. So here we go. We've extracted the tooth. Okay. And now remember, we were trying to make an osteotomy along this slope. Okay. So the fact that the guide helps control the positioning of the osteotomy, you will avoid this natural tendency for your osteotomy to want to tip distally like that. So one of the challenges in this case is preventing the osteotomy from tipping distally. And I think the guide worked really well in this case. So here you can see this is the final implant position. Again, I've got my fixture driver flush with the guide here, means I'm at the position that I planned. Okay, that's what the implant looked like while it was in the osteotomy there. Okay, we have a jump gap around there. So we grafted in the jump gap, placed a healing abutment, and this is what it looked like 1 week later. Okay. Now, this is after healing, about 4 months. You can see we've got a nice tissue profile there that's developed, and we were able to take an impression and place a crown on it. And you can see it's lined up pretty much exactly where we had wanted it. Okay. Now, I want to show you another immediate molar case. This was a case where we had even greater topographical challenges. Okay, so you can see we have a sinus tract that we've traced to the distal buccal root of this tooth number 1-6. Okay, patient decided to have the tooth extracted. She didn't want to proceed with any sort of endodontic treatment for that. You can see that the patient was missing a tooth here, so that this tooth had drifted distally. Sorry, had drifted mesially. And this was a CBCT scan of the distal buccal root. You can see a considerable lesion around there. Okay. This is what it looked like. Okay, and you can see there was a missing tooth there. So we decided to proceed with an immediate molar implant placement in this case. That's where we planned for our tooth to be. You can see where the access hole is. Okay. And that's the mesial-distal position that we had planned in the software. Okay. Came up with a guide. Now, the tooth came out with relative ease, but this topography here is very challenging. Look at we got a trifurcation here, multiple slopes. Trying to control the position of an osteotomy here is very challenging, particularly so because this tooth was sitting distally to where we actually wanted it to be. Ideally, we wanted a tooth kind of in more position in the middle here, so we eliminated the open contact on the mesial. Now, in immediate molar cases, we want to typically put the osteotomy in the furcation. Here, though, we had to kind of shift it over to this direction here along the slope. So this makes it very difficult, even with a guide, because our initial drill oftentimes isn't long enough to really create much of a purchase here. Okay, and if you go in with the guide drill initially, because the guide, if you go in with the actual osteotomy drill initially, it might be too long, and you might not be able to get a guided purchase here. So there's a little trick that I use in these cases. And usually the tools I need for that trick are stuff that's usually already sitting around in the operatory. So this is a round diamond burr. And the first thing I do is I'll make a little purchase here, right where I want my osteotomy to be. Now, sometimes it's hard to visualize that, but guess what? We had already visualized that in the guide hole. So I actually use this hole as a guide to go in and make my initial purchase. Then my next drill that I like to use is a surgical 557. Okay, again, oftentimes once I've made my initial dimple, then I'll take the guide off so I have good visualization of that dimple, and I'll go in and create a little bit of a guide path with this. And then I lengthen it with a precision drill. This is a drill that can be found in your regular Hyoscine taper kit. This just kind of creates a little bit of a what I call a glide path for then my guided drills. At that point, I can put the guide back on and proceed with the osteotomy as normal. And that's what we did here. So we were able to put the implant exactly where we wanted it. You can see where it's positioned there. Okay, and this is a 1 week later soft tissue closure around the site. And you can see where the implant's positioned there. Now, typically, I use a 7x5 healing abutment. When I'm doing immediate molars here, I've used a 6x5. I think it's because I was too lazy to remove this little bit of bone that the 7x5 was getting hung up on. But I don't recommend that. I recommend not being lazy like me and actually using a 7x5, because with the 7x5, you'll have less tissue gap that needs to close around this healing abutment. Okay. So there's our final tooth position there. Okay. Now, one of my first hesitations about using a guide is I used to look at the size of the drills and I'd be like, oh my God, I mean, those are long drills. It's hard enough using regular osteotomy drills in someone's mouth. How am I going to get this in anyone's mouth? You know, I could only foresee it being used in anterior cases, but the one guide system kind of can overcome a lot of those challenges. This is a case where this lady here wanted a wisdom tooth replaced, believe it or not. So she absolutely insisted on it. I tried to talk her out of it. She honestly felt that once the crown broke for this tooth, she did notice a difference in her chewing ability. So this was the 1/8 here, you can see. Okay, and we decided to use a guided solution and did an immediate molar implant placement here. So we've planned for a 5.0 by 8.5 here. Okay, now you can see where we want to put the implant here. Now this is extremely difficult area to work in. I mean, this is so far back in the mouth that your access is brutal. It's hard to visualize anything back there. And this is one of the most least talked about aspects of surgery, any kind of surgery in the mouth, is access is huge. I mean, doing a GBR in the lower and the upper posterior or lower posterior is so much more difficult, I find, than sometimes these anterior GBR cases, just simply because of access, right? So anything that can eliminate that kind of access issue and allow you to use a digitally guided solution is a plus in my column. So there's your wisdom tooth. Very easy to extract these, as you guys all know. I used a Robax forceps and simply just rotated this tooth out. There's the socket. Again, trying to control three-dimensionally an osteotomy here in limited bone, close to the sinus, very close to the sinus, as you can see. Let's back up a few slides here. Yeah, very close to the sinus here, and really just a thin layer of bone here to engage in. And your angulation has to be spot on. So very hard for me to do freehand, but with the guide, I was able to do it. And one of the key features of this guide is you can actually do closed window, which is what I've been showing you so far. But if access is an issue, you can actually get an open window, which allows you to access the guide not vertically like you would do with a closed window, but through the side, a horizontal side access, which suddenly requires less interocclusal space. Okay, so we were able to do that. You can see we have open side horizontal access into the guide for our drills. There's the implant in place. Okay, there's the healing abutment, and we've got some LPRF around there, poncho technique. 1 week later, good soft tissue closure. You see I've used the correct healing abutment here, a 7x5. That's where we wanted the implant. That's where we got it. Okay. So we're able to design a tooth. Pretty good position for the access hole there. Good result. Okay. So I'm going to kind of show you guys the last case here. Now this was probably one of the more challenging cases, but it just shows you the power of using a guide to really control implant position in critical cases here. So this is an anterior edentulous span here. This lady had had 2 bone grafts prior to coming to me. Okay, so very limited bone. We plan to do an implant supported bridge here with an implant in the 1-2 location, another in the 2-3 and 2-2 location. We wanted to avoid the central incisor areas, and you'll see why later. She had a massive nasopalatine canal. So 2 bone grafts, and this is the kind of bone width we have to start with in the different sites. Clearly not enough bone to place any sort of implants. This is the 2-1 to 2-3 segment. You can see how paper thin that bone is. So this, I had my work cut out for me on this one. So we went ahead and grafted. This is after my first graft. Okay, this was the kind of result I got. Not very impressive. One critical mistake that I made was I let her wear her existing partial after I did the graft. What it had done is this location here, it had melted a lot of the palatal bone that I was trying to grow. Okay, so I decided to kind of push the guide to its limit here in this case. So I sent the scan, took the records. We virtually planned where we'd like the implants. And as you can see, we'd have the implants sticking out of bone if we went ahead and placed them this way. So this is kind of prosthetically, this is where we wanted the implants to be. Unfortunately, we just didn't have the bone there. Okay, so what do you do when you don't have bone? You have to make bone. So I wasn't going to compromise with the position of the implants. This is the massive nasopalatine canal I was talking about, which further made things more challenging. So this is the guide we made. Okay, I wasn't sure if I was going to actually place implants when I went in. I just thought I'd make the guide just for the hell of it. Okay, you can see we've kind of even pushed the guide to its limit here. Okay, so we used a combination of ridge expansion, and we were able to actually get the implants engaged right against the palatal bone in the correct trajectory at the correct position. Of course, I can't leave the implants like this, so I had to do a massive guided bone regeneration around there. You see some membrane holding sutures. We used a Cytoplast RTM with 50-50 LifeNet allograft here. Okay, lots of PRF. I mean, I'm kind of throwing everything I have at this case. This was not a case that I would do again. But the patient was great. She was very understanding, and we thought we'd give it all we had. So this was the closure. Now you'll notice I used a lot of PRF in my surgeries. In this case, I even used a pre-flap IPRF injection just to optimize vascularity. The last thing I wanted was flap opening. And a week later, you can see nice pink coloration to the gingiva, good vascularization. Okay, so that's what we started with. And this is kind of what it looked like 4 months later. You can see we got, actually in this location here, we got a ton of bone, even palatal bone. This time I did not let her wear her partial. We gave her an Essex to wear in the meanwhile. And we got good bone around all the implants. These are the implants at uncovering. Okay, what started off as this now looks like that. And there they are. That's her in the temporary stage. There you can see the emergence profile. So my point is, if you can get the implants in the right position within the bony envelope, you have a chance to actually graft around them and have it work successfully. Okay, so the key is really being able to control the positioning of the implants. And I don't think I could have done this case without the guide. There's her final prosthetics, and she's very happy with the result. I mean, she was a super good patient, and very happy with the result there. So that pretty much concludes the cases. I just want to finish off with a little bit of summary of the benefits that I find in my practice for using digitally guided one guide solution here. First and foremost, just the communication tools, just having the report, being able to plan it with precision and communicating this to patients. Like I show my patients these reports before the treatment, and it's really translated into a much higher case acceptance for me. Not to mention the precision of the treatment. I mean, I can do my treatment much quicker, more precisely, and I'm finding that the quality of my outcomes just has increased tremendously with the guide. Okay. Also, in some of these cases, like this full arch case, where we're planning for a locator solution, parallelism is absolute. So not only am I getting precision, but I'm able to do it in a flapless way. This photo was taken right after surgery. There's no flap, very quick treatment, no swelling. Patient's very happy. They had 7 implants placed with 2 sinus lifts here. We did crestal sinus lifting. So, I mean, this was a medical doctor. We did this on, he couldn't stop raving about how he felt no pain after. Just the incredible level of patient comfort that this can afford us. Also, I'm finding my communication with the treatment network, with my lab, with the One Guide team, using this digital interface just makes for such an improvement in our collaborative capabilities. And finally, I mean, when you combine precision with a time savings, there's no way that's not going to save you money. So this has been, it's actually been a cost savings in our office simply because of the amount of treatment time that it's freed up, chair time that it frees up. Also, with higher precision and more predictable outcomes, I get less complications. And complications take up time and money, right? So in my mind, digitally guided implant solution is truly reverse treatment planning, and really is implementing the notion that you're beginning with the end in mind. And that brings me back to Sun Tzu's quote. Like, if you want victory, you have to win first. And in our case, we win when we do the simulated surgery, when we do the digital planning, find the right position. We've got it all figured out even before we've gone to battle, right? So you win first and then go to war, and not just kind of open up a flap and then deal with it. It's just so much smarter, cleaner, easier way of doing it. I mean, in layman's term, it's like, don't get caught with your pants down, right? So that pretty much concludes my webinar. Thank you so much for joining me. Feel free to email me with any questions. So email's right here, rogerrick1981@gmail.com. And I believe there will be a quiz now that'll be coming up. And I've tried to make it very easy for you, as a lot of the answers were in the lecture. So best of luck, and I look forward to seeing you guys again, and stay safe.